Good morning. Thank you so much for inviting me to this beautiful country. I hope we can share our experience with allergen components and allergen immunotherapy today. Here you have my disclosure. And well, I don't need to say here that it's not the same to be polysensitized than to be polyallergic. As you know, when you are polysensitized, the clinical relevance is unknown. Perhaps people can have positive skin prick tests, but without any clinical relevance. And then we say that it's polysensitized, but it's polyallergic when the clinical relevance is really high, and it's important to treat this patient. And that's the reason why we have performed in Spain a consensus trying to help physicians to know which is the best treatment for our patients, to select proper allergen immunotherapy, the composition of the allergen immunotherapy in our patients. And that's because Spain has different regions, has different sensitization profiles. Our patients are really different from one place to another. So it's very difficult to assess the clinical relevance of all these allergens that we test in our patients. And the main conclusion of our study was that we need specific tools to help us with the diagnosis, and so that without these tools, we cannot properly prescribe allergen immunotherapy to our patients. And you all know that an extraordinary progress has been made in the field of allergen extras for especially diagnostic purposes, using the application of DNA technology, because it led to the development of the so-called component-resolved diagnosis or molecular diagnosis. And why? Why is this really important for us? Because it's useful to define the allergen sensitization profile of one specific patient, because it's useful to identify the potential disease-eliciting molecules. It's useful to improve diagnostic accuracy, and so we can differentiate genuine sensitization to cross-reactive allergens sensitization, to assess also the risk of an allergic reaction, because, as you know, it's not the same to be allergic to propylene than to be allergic to LTP, for instance, and, of course, to improve the identification and the selection of the best vaccine for our patient. So, which is the best allergen to treat our patient? But, well, sometimes when we receive the results of this molecular diagnosis, it's really difficult to understand and to interpret, because we know that there are many different molecules, but we don't know everything about the epitopes. So it could be that some different allergens share a common epitope, and on the other hand, some similar allergens do not share anything at all. So it's not so easy to interpret the results of the allergen component resolved diagnosis. So let's see the meaning of different allergens' behavior and how they could help us to select the best allergen immunotherapy for our patients. And we can start with, of course, house dust mites. As you know, house dust mites are really relevant allergens, at least in our region. 80% of our people in Galicia, in the northwest of Spain, are sensitized against house dust mites. And we all know that DERP1 or DERP2 or DERF1 or DERF2 are considered major allergens, because more than 50% of the patients allergic to house dust mites, to dermatophagoides, recognize DERP1 or DERF1 and DERP2 or DERF2. And we know many things about these two allergens. We know that they interact in the immune system with the adaptive response. We know that DERP1 disrupts the bronchi epithelia, so let DERP2 to enter and favors the sensitization. We also know that DERP1 stimulates DERP3, 6, 9, and then all of them are released with feces, and that DERP2 together with RP5, 7, 13, 14, and 21 are lipid-binding proteins. But from the clinical point of view, we know that there are other allergens that are relevant apart from DERP1 or DERP1 and DERP2. For instance, here you have the results of a study published some years ago by Retz and co-workers, where you can see that children that are sensitized against DERP1 have a higher risk of suffering from asthma. In a similar study, the same group has published that when patients recognize DERP1, DERP2, and DERP23, the risk of suffering from asthma is really, really higher. And these results were reproduced in a different country, in Manchester, in England, and the group of Adnan Kustovic showed that children with what they call a complete mite sensitization, meaning that they recognize many different allergens from dermatophagoides and also allergens from other mites, such as Lepidoglyphus or Blomia, have a higher risk of suffering from asthma and a higher risk of an asthma exacerbation. And here you have the differences between those with or without this panel of sensitization. And in Spain, in a region, we have proven that similar results can be seen in adult population. Here I can show you that, for instance, patients that recognize DERP1 plus DERP2 are at higher risk of suffering from asthma in an adult population in Galicia. So, yes, DERP1 and DERP2 are relevant. DERP10 is not so relevant, and in the past they said that almost all patients allergic to house dust mites recognized DERP10, and it was really clinically relevant because of some clinical symptoms when eating shellfish. But that's not really confirmed in different studies. For instance, in our population, less than 10% of our patients recognize DERP10. But there is another one that is really important, and is DERP23. DERP23 can be recognized by 74% of patients allergic to dermatophagoides. And in the region where I work, 89% of our patients recognize DERP23. But the problem is that we don't have extras with DERP23 quantification. So we only have extras for treatment with DERP1 and DERP2. And some of them have a very different amount of allergens in their content. Look, for instance, at this study. It has been published by a Spanish group. And here you have the molecular weights. Here you have one sublingual immunotherapy extract. This another sublingual immunotherapy extract. Here you have DERP1. Here you have DERP2. And here you have different extras, 3 different extras with no allergen content at all. So when we are giving these extras to our patients, we are giving just water. So my God, what I'm going to do. Okay, we should try to identify if our patients have specific IgE against DERP1 or DERP1 and DERP2, and we should try to offer a product in which the amount of at least these 2 molecules are well quantified. Let's go to pollens. Well, there are many, many different pollens, and I could see here you have many olive trees, so I think that olive pollen should be a problem here, I guess that. And when we perform a skin prick test, are we sure that we know what is clinically relevant for our patient? I think no. For instance, in Spain, we have different regions. So depending on the region where you live, the probability of being sensitized or of being allergic is different. For instance, in the south of Spain, olive pollen is really important, as well as grass pollen. But for instance, in the Mediterranean area, there are many other pollens, especially from weeds, that could interfere. And where I live here, we have betula pollen apart from grass pollen. And when we look at the calendars of symptoms, when we ask our patient, please sign which days you feel worse, we can see that many different pollens coincide at the same time in the atmosphere. So it's very difficult to know which one is really relevant. Can we do anything else? Yes, we can perform perhaps provocation test. The problem is that before prescribing allergen immunotherapy, it's really difficult to perform this kind of test in all patients and with all allergens because it would take too long. But we are sure that skin tests are not accurate. And many different articles have been published dealing with this problem. The problem of the different sensitization profile against different allergens. And we can see an example. Imagine that you have a patient with all these skin prick tests that are positive, and as you can see, we have grass pollen, plantago, betula, different olea, fraxinus, quercus, parietaria, but we also have profilin and polcalcin, and the patient is sensitized to dermatophagoides. If we perform serum-specific IgE against the crude allergen, we will have results like this. So it's almost the same. We have spent a lot of money and we add nothing to the previous diagnosis. But when we select allergens and instead of performing of these total specific IgE against these crude allergens, we select the components, we can reach a diagnosis. Look at this. For instance, we have parietaria, we have profilin that is positive, polcalcin that is positive, meaning that these positive results are due to profilin or polcalcin. We know that the patient is not allergic to grass pollen because FeLP1 and FeLP5 are negative, almost negative, but look at this. Par J2, meaning that Parietaria judaica is relevant, is really, really high. So it seems that Parietaria immunotherapy is the best option for this patient, but it was not the first option. Just looking at the results of the skin prick test or the serum-specific IgE against the crude allergens. And you have some kind of algorithms that could be of help to select the more adequate allergen immunotherapy. If you perform the clinical history, the skin prick test, and then you can see, oh, well, my patient is only sensitized to grass pollen, so there is no problem at all. But I have many, many different positive results. So what I can do is perform this kind of component resolved diagnosis and looking for the specific response. We have two different kinds of components, those that are recombinant and those native. In the case of those that are native, we have the problem of the cross-reaction with cross-reactive carbohydrates. So they could be positive due to a positive recognition of these carbohydrates. So in that case, when it is positive, we can think that the patient is suitable for allergen immunotherapy. What is more debatable is the role of profilin and polcalcin, because in some cases, and in some studies, they have proposed that those patients with a positive response to profilin or polcalcin will not be good candidates for allergen immunotherapy. But in fact, we don't know the answer. We don't know the answer to this question because no placebo-controlled study has been performed to demonstrate that it is good or not for our patients. But component resolved diagnosis could be of help for any other things. For instance, to assess the safety of allergen immunotherapy. In the case of olive pollen allergy, you know that there are some extra that could give some systemic reactions. And in this study, performed in Spain as well, they have demonstrated that those patients with a positive response to OE7, that is an LTP, are at risk of suffering from systemic reactions. So perhaps we could measure OE7 in these patients. Moreover, when talking about grass pollen, we know that those patients that recognize many different molecules from grass pollen are at higher risk of suffering a systemic reaction. And also, this kind of approach could be of help to know that sometimes molecules that seem to be so similar are not, in fact, so similar or induce no similar responses. Look at this study. In this study, they use MALDI-1 and BETB1 to patients with birch pollen-related apple allergy, and they could demonstrate that only those patients treated with MALDI-1 experiment or improve their symptoms of oral allergy syndromes after being treated, but not with BETB1. Pets. Okay, there are many different allergens from pets, but almost all of them belong to 4 different families: secretoglobulin, lipocalin, calicrain, and albumins. And these are the most relevant ones because these are the ones against we have some allergen immunotherapy products. In the case of secretoglobulin, it's important because it is the major allergen in cats, FeLD1. 95% of cat allergic recognize this allergen. And as a curiosity, you know that there is this other molecule that is a human homologue, but the function is unknown, and we don't know if it could induce any kind of problems. Lipocalins, well, they are spread all over the furry animals, and more than 50% of all allergens from furry animals belong to this family. So we have lipocalins in dogs, CANF 1, 2, 4, and 6, and the degree of cross-reactivity is really high. We also have these kind of molecules in cat allergic patients and also in horse allergic patients. With respect to calicrain, it's important to know that CANF5 is a calicrain, is a prostatic calicrain, so only male dogs have this allergen. It's important because if a patient is allergic to this allergen, then they could have a female dog. And it has some cross-reactivity with human seminal fluid that could induce problems when having children. And finally, the albumins, and we have albumins in cats, in dogs, and of course in horses. So, if we are looking for the allergen immunotherapy, we can see that cat allergen immunotherapy seems to be more useful, more efficacious than dog allergen immunotherapy because it has been proven that it reduces the asthma symptoms. However, some studies using exposure chambers did not prove this beneficial effect. And in the case of horse allergen immunotherapy has been proven to be efficacy, but it was not in a placebo-controlled study. One relevant problem that we could have in the future when using these kind of allergens is that crude allergens of cat, dog, and horse could increase the sensitization against allergens that were not previously recognized by our patients. So perhaps we are treating the patient, but we are creating a new problem. And perhaps the future could be the use of hypoallergenic formulas or peptides, such as those that have been used in intralymphatic immunotherapy by Gabriela Senti in Switzerland. Well, I'm going to finish with molds, and especially with Alternaria. And you know that the main allergen of Alternaria is ALT-A1, and it's recognized by almost all patients allergic to Alternaria, so there is a big problem in recognizing this allergen in our patients. And I can show you that there is a study that it will be published soon, performed by a Spanish group in which they have done a double-blind randomized placebo-controlled study using a specific vaccine of ALT-A1, and it proved to be efficacy. Well, cockroach, it has many different allergens, but we don't have a vaccine, at least in Spain. I would like to finish my presentation with this study. because, we are talking about the component resolved diagnosis, but this study is not based on molecular diagnosis, it's based just in the profile of sensitization of children and the children with asthma. This has been performed by Jocelyn Just in France, and she decided to classify children into different clusters, depending on the severity of asthma, the exacerbation, and the sensitization profile. So, in cluster number 1, children suffer from moderate severe asthma. They have frequent exacerbation and multiple allergen sensitization. In the cluster number 2, the asthma is also moderate to severe. The exacerbations are frequent and they are allergic but to several pollens, but not to different non-related allergens. In the cluster number 3, include patients with mild asthma, no exacerbation, and multiple allergic sensitization. And in cluster number 4, patients with mild asthma, no frequent exacerbation, and allergic to house dust mite. I will add here cluster number 5 with severe asthma, frequent exacerbations, and house dust mite allergy. Well, these authors select that these 2 different groups of patients are good candidates for allergen immunotherapy, while these others would be good candidates for a biological treatment in the case of the moderate to severe asthma. So, in conclusion, we can say that skin prick tests are useful, but are not enough to accurately diagnose allergy in patients that are polysensitized. That, of course, molecular diagnosis could be of help. I know because they told me before that here is very expensive. I could give you an alternative. And, of course, the third conclusion is that allergen immunotherapy should be prescribed based on scientific evidence, and clinical data and knowledge of allergen exposure are essential, of course, and each vaccine should have its own safety and efficacy studies. No class effect can apply here, as I told you in the case of the sublingual extras for house dust mites. And I would like to invite you to Lisbon to the next IACI Congress in June. Thank you so much.